Hello everyone, welcome back. It's Elizabeth, and right now we're going to take a look at the patient concept map for Parkinson disease. So let's go ahead and dive in here to Parkinson disease. We'll just do a real quick kind of down and dirty of the patho, and then we'll kind of get a little bit deeper. So the big things here are that this is a progressive neurodegenerative disease. So this is going to continue to progress for the rest of the patient's life once they're diagnosed, and it is going to cause just some ongoing degeneration of the neurologic system. And the big issue here is that we have a decreased amount of dopamine available to the patient in the patient's brain. So the reason that that's important is because the neurotransmitters, dopamine and acetylcholine, are responsible for fine motor movement. And so because of that, some of the issues that we see in Parkinson disease is affecting fine motor movement. Dopamine is produced in the substantia nigra, okay, and in Parkinson disease, the substantia nigra degenerates, and this causes the decreasing levels of dopamine, and that results in the loss of voluntary movement. Also, dopamine losses reduce the sympathetic nervous system response, resulting in orthostatic hypotension. So the sympathetic nervous system is that thing that gets activated whenever a bear is chasing you. So, when you think about the sympathetic nervous system, it helps to increase your heart rate and increase your blood pressure and all of that. So if that is not functioning properly, especially specifically in these patients, when they stand up, their blood vessels don't constrict like they should, so that they can, put more tone into the blood vessels to work against gravity, so we can get that blood up to the brain now. It doesn't work like it should, and so then the patient develops orthostatic hypotension, which is just a decrease in the blood pressure when the patient changes positions, such as from lying to sitting and from sitting to standing. And the causes of this are thought to be environmental and potentially some genetic factors. There's a very rare form of genetic Parkinson disease, but they think maybe it's just, some different things that kind of all come together to create this problem. And they also have found some association with exposure to pesticides and industrial chemicals. So we will go over here real quick to the concept map and take a look at the assessment portion of our patient concept map. The things that you're going to see in your patient that has Parkinson disease, they are going to have 4 cardinal symptoms, and these are going to include a tremor, which is just like a shaking that can occur, anywhere. Sometimes it's the jerky head, the jerky hands, sometimes they're just kind of jerky all over. It's a tremor, okay? And then muscle rigidity. So this patient no longer has smooth movements of the muscles, okay? Their muscles become very tight and rigid and difficult for them to move. Bradykinesia. Brady means slow. Kinesia means movement. So they have slowed movement. So they just move at a much slower pace than what they are typically moving at. And then postural instability, which just means their posture is unstable. So they kind of have a center of gravity that is off. So instead of standing straight up and, knowing I'm standing straight up, they're kind of maybe leaning forward, and they're just more likely to kind of fall because of that. Those are the 4 cardinal symptoms. So these are the kinds of things that they're looked at to be diagnosed with Parkinson disease. They use a test called the get up and go test. So they're supposed to, quickly get up out of their chair and take steps. And if they're having difficulty making that quick movement to get up, that is a sign of Parkinson disease, along with like the tremor and the rigidity and these types of things. But then also in your patients that have Parkinson's disease, you're going to see some other things that kind of arise. And that includes a mask-like face. And so that is because the fine motor movement in our face is not working like it should. So they may develop less movement in their face. And so they kind of have like a masked appearance. They may develop problems with chewing and swallowing, again, because those muscles that are kind of working to do that don't move like they should. These patients commonly develop dementia. It's very common for them to develop dementia. And like we already said, they may have orthostatic hypotension. They have emotional lability, which just means their emotions are just kind of all over the place. Like they might be happy one minute and then all of a sudden you say one thing and then they're just really sad or really angry, or, they just don't have good control over their emotions. Constipation is a common problem. And I think that they have decreased movement. So, your intestines are moving kind of things through there and that's not working like it should. So that might be part of the issue there. And then commonly they will develop some weight loss. So those are some of the things you're going to see in your patient that has Parkinson's disease. A lot of times when you learn about Parkinson's disease, you're going to see this little old man that's kind of leaning forward and shaking and has slow movements. So that's kind of the representation, kind of a visual to just can't like take a step. It's kind of shuffled because they just can't move like they should. And then it's common for them to have this thing called freezing, where they're trying to ambulate, but then all of a sudden they just kind of like get stuck and they can't go, okay? And so having a ambulatory aid like a walker, things like that. There's a whole video out there on moving big with Parkinson's disease, and it's really interesting. There's probably multiple videos. It's something physical therapists teach patients with Parkinson to try to overcome the issue of freezing. Okay, so that's your assessment piece there on what your patient's going to look like. And so then we can kind of move into the testing portion. Really Parkinson's disease is a clinical diagnosis. And so that just means that the cardinal symptoms that we talked about and an examination from a neurologist is really going to be how these patients get this diagnosis. It's not like they do some simple blood test or some certain thing and they say, oh, this patient has Parkinson's disease. No, it's more of like a clinical diagnosis. So it's not really based on labs and imaging. Now, a lot of times a good provider is going to do some testing to rule out other causes for this just make sure it's not like caused by something else. And so some of the other things they might do would be MRI, so getting a good image of the brain just to see exactly, make sure there's no structural problems in the brain that's causing the symptoms the patient's having, and then a lumbar puncture, which is where they kind of go into the spine and get some fluid out of there and test that for different medical problems. And then they can do this SPECT lumbar puncture, which does detect decreased levels of dopamine. So that is an interesting thing that they may do to help diagnose Parkinson's disease. Okay, now we are going to move on into these interventions. Okay, so like I already said, physical therapy gets really involved in these patients who have Parkinson's disease. So exercise therapy, maybe physical and occupational therapy may help with some plans for these patients on how to decrease their risk for falling, since they are having problems with movement. And then there is surgery, and these include stereotactic pallidotomy and deep brain stimulation. I definitely think the deep brain stimulation is one that is the most common probably, but still not really that common. I don't see it a ton, but I also live in a smaller area, so that might have something to do with that. Then we have lots and lots of medications, which we're going to discuss about ways that can help. Multiple different mechanisms of actions of medications to help treat Parkinson's disease. And then a lot of times we're trying to get the opinion of our dietitian, or this could also be a speech language pathologist, which is the ancillary staff that kind of works with swallowing. So with a dietitian or a speech language pathologist, SLP, on if the patient needs to have thickened liquids, if the patient needs to be on a puree diet, that's easier to chew and easier for the patient to eat without having choking. And then they usually suggest a high protein, high calorie diet just to help decrease that weight loss problem that we kind of get into in the patients with Parkinson's disease. So just a little closer look at this stereotactic pallidotomy. And this is where areas of the brain are destroyed to help reduce tremor and rigidity. So that's kind of what they do with that one. And then deep brain stimulation. This is where electrodes are placed in the brain. So they put these little electrodes in, and they connect to a device called a pulse generator, and that is implanted under the skin, sort of like a pacemaker. So they might have like a little thing implanted under the skin. And the whole point of this is to decrease the need for levodopa, which we're going to talk about here in detail. Levodopa, common medication used to treat Parkinson's disease. So now we're going to go into these medications. There are lots of them. You don't have to memorize all of them. I think being familiar with them is a good idea. The big one here is this carbidopa, levodopa. Okay, that one I think you should know pretty well. But these others, just kind of have an idea that there are multiple ways to treat this, and they may be used at different parts, different stages of the illness, of the disease. This is a progressive disease, so that there are specific stages of it, so kind of like the earlier into the progression of the disease. So they kind of started out as stage 1, stage 2. We're getting worse as we're going on to stage 5, which is, really severe. You don't have to memorize that, I don't think. It's just knowing that it is progressive, and we use different medications, sometimes at different stages, to treat it based on how the patient's doing. So dopamine agonists, okay? And we already know that this is a problem, this disease is a problem with dopamine. So agonists, that helps get more dopamine, okay? So dopamine agonist stimulates parts of the brain influenced by dopamine. So the brain thinks it's receiving dopamine. Okay, that sounds good. We can get some more dopamine in there, or at least trick the brain to think that we're getting dopamine. That should help us with some of our fine motor movement. So examples of this are pramipexole, ropinirole, and rotiagine. And these are this one is a transdermal patch. So that's nice. You don't have to take a pill. We can just slap this patch on you. So that's, a different option. And then here's the one that's really widely used, okay? And it is carbidopa, levodopa. Levodopa helps replace missing dopamine in the brain, okay? So some people say that this, leaves the dopamine in, okay? Levodopa leaves the dopamine, keeps dopamine in the brain. And carbidopa keeps the levodopa from breaking down in the bloodstream before it crosses the blood-brain barrier, okay? So sometimes medications will be in the bloodstream, and then, like specifically this one, by the time it gets to the blood-brain barrier and crosses over, it may have been used up and it may not work. So we need something to help it get across the blood-brain barrier, okay? So levodopa leaves the dopamine in, and carbidopa is the car that drives the levodopa to the brain. Okay, so that's how you remember that. Those are always given together. They're prescribed together. It is a pill. It is one pill that's got both medications in it. Okay, and it is the mainstay of therapy for this illness. And it must be given on a routine schedule. So it's usually like every 6 hours. It's given. It's not that long acting, so it's given pretty often. And if we miss a dose or don't give it for a while, then the patient's, it's like an abrupt noticing that it's not there, because it really helps the patient. And then if we're late on the next dose, then the patient starts to have their symptoms back, and it can be really frustrating for the patient. It does decrease the absorption of the levodopa if we're taking in high protein foods. So if I already have a bunch of high protein foods circulating, and then I take the levodopa, it doesn't absorb as well. So, high protein foods are recommended for patients with Parkinson disease because they're losing weight, so they need protein. But maybe it would be better to give that at bedtime, or not, when the patient's movement's super important, or right with their carbidopa-levodopa dosage for the day. The problem with this medication is that they can develop a tolerance to it. So it was like, oh, they took it and it helped so much, but then the longer they took it, the higher their dose had to get, and then it didn't work as well as what it did at one time. So to combat this, they may have to have a drug holiday where they don't take the drug for a while, and then we restart it and hope that we're not going to have to go up to high doses again. We can stay at a lower dose for a while until they develop tolerance again. Or we might decrease the dose for a while and then gradually increase if we need to. Or change the drug regimen. So as I said, there's multiple things we can use to treat Parkinson disease, so we may just have to go a different route if the carbidopa-levodopa isn't working like it used to. Okay? And then we have COMTs, and we don't need to know this big giant word. We just know these are COMTs, and they are enzymes that inactivate dopamine, and they prolong the action of levodopa. So this medication is specifically used at the same time as this medication because it helps to prolong the action. Okay, entacapone or tolcapone. Okay, those are those ones. And then we have MAOBs, or they may also be called MAOIs, and they're used for early and mild symptoms, and they slow monoxamine oxidase in the brain, which increases dopamine concentration. So it helps to make more dopamine. That's basically what a lot of these medications do, is they either keep the dopamine from breaking down too fast, or they make you think you got more dopamine, or they give you more dopamine. So the thing about these medicines, which I don't know if you need to know it specifically for this, but just in general in nursing and in nursing school, I feel like you probably do need to know that MAOIs interact with foods containing tyramine. Okay, and so this could be aged cheese, sausage, red wine and beer, and they may get a headache and life-threatening hypertension. Okay, so they may get a blood pressure that is astronomical. So they have a lot of dietary restrictions with MAOIs. Okay, so also a lot of medications don't get along with MAOIs, so we try not to use them because they just don't get along with anything, and it's a pain for the patient. But sometimes we do use them just to try to treat symptoms. So rasagiline and selegiline, those are examples. Okay, and then we have dopamine receptor agonists. Okay, so this helps the receptor get more dopamine, so it promotes the release of dopamine from the dopamine receptor. Great. Bromocriptine, that's that one. Okay. And then we have medical marijuana. It's becoming a new kind of thing, over the past several years, that medical marijuana is being used for more and more things. So patients have reported decreased symptoms such as tremor and dyskinesia, pain, insomnia, and depression. So that's wonderful. Like with a lot of new things that we would use, such as medical marijuana, more studies are needed to really say, oh, this definitely helps. But there are some interesting videos out there of patients with Parkinson disease that try medical marijuana, and they record like how they look before and then how they look with the medical marijuana, and that's really interesting. But you know, like with a lot of things, different things work for different people. So just because that worked for the guy on YouTube doesn't mean it's going to work for your, 68-year-old guy that you got in your long-term care. So just everybody's different. But it is interesting. One thing I didn't mention up here that I probably should have mentioned is depression is extremely common in these patients. So it was saying, that the medical marijuana helps with depression. It's a very common problem among patients with Parkinson's disease is depression. Of course, it's depressing to receive a long-term diagnosis, but I think, it really has something to do with the lack of dopamine and things like that kind of causes the depression in these patients. So extreme, so the things we really need to watch out for in our patient with Parkinson, swallowing difficulties can lead to aspiration pneumonia. Okay, so choking and aspiration and all of that, big problems. So we really need to make sure they're on the correct diet and make sure that we're getting consults from those outside sources if we need help. Okay, and then injuries due to falls related to mobility problems and orthostatic hypotension. I also didn't mention this, but a lot of those medications that the patients take for this problem specifically, some of the side effects are orthostatic hypotension. So here we have this patient who's already at risk for orthostatic hypotension based on the disease process. And then we also are giving them medications that can cause them to have orthostatic hypotension. Huge fall risk, huge risk for injuries. Okay, so really trying to keep this patient safe. Okay, let's go down here and look at our nursing diagnosis. Decreased mobility due to rigidity, tremor, and gait changes. That makes sense, right? We got decreased mobility. And then impaired cognition due to changes in transmitters of the brain. So, like I mentioned, depression and dementia common in these patients. They can also have hallucinations even. So, impaired cognition. All right, what are we going to teach these patients? Oh, we said we were going to teach them to change positions slowly because we don't want them to have an injury. So if we can really make sure that they're changing positions slowly and letting their body kind of adjust before they go hopping up and taking off somewhere, that's really going to help to prevent falls. And then encourage measures to improve constipation. So, there's all kinds of things we can do for constipation. Exercise is one. And then there's a whole regimen of like stool training, stool softeners, things like that can kind of help with constipation. So getting that taken care of. And then fall precautions, which, there's a lot of things that kind of go into that. And these can be used for lots of different types of patients, but certainly our Parkinson's disease patients need some good fall precautions. So here we are, we got sure that we don't have a lot of throw rugs and clutter around our house because, if that throw rug, if I'm not really able to take a big step, I might get my foot caught on that when I'm shuffling through the living room, and then boom, I fall and I'm injured. And then clutter, if we got just a bunch of stuff sitting around, we're more likely to trip and fall. Okay. Provide good lighting. So obviously, like a lot of these patients are older. They don't have to be, but a lot of them are older. And if you can't see very well to begin with, because your vision kind of decreases with age, and then you're already having difficulty walking, we just want to make sure you really have enough light to be able to see where you're going. And that is especially true at night when you're going to the bathroom. So they may be getting up to walk to the bathroom. We want to make sure that they have a good source of light so that they don't fall on their way into the bathroom. And then remove all wires and cords from the pathway. If you've got a extension cord drug across, or oxygen tubing, or, something like that, it's real easy to trip on that. So easy. And then use non-skid mats in the shower. So that way we're not slipping when it gets slippery. And then also like the non-skid soles on our shoes or socks, that kind of thing. And then grab bars in the bathroom to keep us, give us something to grab onto if we feel like we're about ready to go down. So that's most of the things with this. I do think a lot of times we need to teach these family members to kind of let these patients do as much as they can, because they need to not lose what abilities they do have. So I think that's the story on Parkinson disease, and I hope you learned something.